Welcome to another episode from the Veterinary Medicine Digest. Imagine, if you will, a quiet Tuesday afternoon in a busy specialty referral practice. A Labrador retriever is rushed through the front doors. The owner is frantic, describing how their dog was playing a vigorous game of fetch just an hour ago, when he suddenly let out a yelp and collapsed. Now the dog is dragging his hind limbs. As a clinician, you perform your neurological examination, and what you find is perplexing. The hind limbs are limp, flaccid, and heavy. When you pinch the toes, there is no pullback, no withdrawal reflex. The muscles have no tone. Classically, this clinical picture points toward a lesion in the lumbar intumescence, the segments of the spinal cord from lumbar 4 to sacral 3. But the imaging tells a different story. The lesion is high up in the thoracic spine at thoracic 12. This is the great mystery of spinal shock, a physiological phantom that haunts the emergency room and challenges our fundamental understanding of neurolocalization. The term spinal shock was first introduced into the scientific lexicon in 1841 by the physician Marshall Hall. Hall observed that when the spinal marrow was suddenly divided, there was a temporary period where no diastolic actions or reflexes could be elicited in the extremities before they eventually returned. Before Hall's description, the phenomenon had been noted as early as 1750 by Robert Wett, who described a loss of sensation and motor paralysis followed by a gradual recovery of reflexes, though the anatomical basis for these events was not yet understood. In 1890, another researcher named Bastian defined the condition as a total loss of function below the level of a complete severance, believing the extinction of reflexes to be permanent. However, the legendary neurophysiologist Sir Charles Scott Sherrington eventually replaced the idea of permanent extinction with a temporary one, establishing the definition of spinal shock we use today, a transient extinction of reflexes below the level of an acute spinal cord injury. To understand the scandal of spinal shock, we must understand the motoneuron membrane. James Schatt and Charles Barnes performed critical research into these membrane changes, noting that following a thoracic spinal cord transection in a decerebrate cat, the forelimbs exhibit an enhanced extensor stretch reflex, while the hind limbs suffer from increased thresholds for reflexes, a hallmark of spinal shock. Their work revealed that during the onset of this phenomenon, lumbar alpha motoneurons actually hyperpolarize, meaning they become less excitable. This hyperpolarization appears to be caused by the sudden removal of descending facilitation from the brain and brainstem. Effectively, the neurons are waiting for a signal from above that never comes, and in the silence, they lose their ability to respond to local stimuli. Schatt and Barnes's research into the Schiff-Sherrington phenomenon, the increased extensor tone in the forelimbs when a thoracic lesion occurs, showed that, while the hind limbs go quiet, the forelimbs are released from ascending inhibitory influences, creating a dramatic and often misleading postural display. But what is happening at the molecular level during this period of flaccidity? This is where the work of Richard Simpson and his colleagues becomes vital. They hypothesized that amino acid neurotransmitters play a primary role in the maintenance of muscle tone and that abnormal concentrations are behind the hypotonic states seen in spinal shock. Using rabbit models of ischemic spinal cord injury, they discovered that flaccid animals had baseline levels of glycine that were 2 to 3 times higher than those in spastic or control animals. Glycine is a major inhibitory neurotransmitter in the spinal cord, residing chiefly within the segmental interneuron pools that communicate with alpha motoneurons. This suggests that spinal shock isn't just a loss of excitation. It is an active state of inhibition where high concentrations of glycine suppress the expression of reflex activity. This chemical flood may be the result of a transmitter release from critically injured interneurons, or a consequence of the inflammatory response that follows an acute injury. In humans, researchers like Blair Callancy have used tendon reflexes to predict movement recovery, noting that persons with acute spinal cord injury who retain large tendon responses, even in the presence of paralysis, have a much better prognosis for becoming motor incomplete rather than motor complete. Their study of 229 human subjects showed that the presence of a crossed adductor response to a patellar tendon tap was a highly specific indicator of preserved supraspinal control. If these reflexes were present at the acute stage, the accuracy for predicting eventual motor recovery exceeded 91%. Calancy points out that while spinal shock results in an immediate and prolonged depression of stretch reflex excitability, this depression is most profound in those with neurologically complete injuries. This distinction is critical because it tells us that if we see reflexes in a paralyzed patient, the cord is not fully dead. There is still communication spanning the injury site. The evolution of spinal shock is best understood through a four-phase model proposed by John DeTuno and his team. Phase 1 occurs in the first 24 hours and is characterized by areflexia or hyporeflexia due to the loss of descending facilitation and motoneuron hyperpolarization. In Phase 2, which lasts from 1 to 3 days, we see the initial return of reflexes, likely mediated by denervation supersensitivity, and the upregulation of receptors like the N-methyl-D-aspartate glutamate receptor. Phase 3, occurring from 4 days to 1 month, involves early hyperreflexia driven by new synapse growth from short-axoned interneurons. Finally, Phase 4, which can last up to a year, results in late hyperreflexia and spasticity as long-axon neurons and soma-supported synapse growth take over. This model highlights that the resolution of spinal shock is not an abrupt event, but a slow transition into a state of heightened excitability. In the clinical veterinary world, Amanda Full and her colleagues reviewed 263 dogs to understand how this phenomenon presents in our canine patients. They found that dogs with thoracic lesions were significantly more likely to develop spinal shock than those with lumbar lesions. In their study, fibrocartilaginous embolism was the most common etiology for spinal shock, though intervertebral disc herniation and acute non-compressive nucleus pulposus extrusion were also represented. Most of these dogs, over 90%, showed improved or normal reflexes within 60 days of the injury, suggesting that while spinal shock is dramatic and frightening, it does not necessarily mean the patient will never walk again. Their data showed that the pelvic limb withdrawal reflex was the most frequently depressed, while the patellar reflex was often spared, providing a key clinical clue for localization. The prevalence and clinical significance of spinal shock in dogs were further explored by Amy Hodgson and William Thomas, who found a prevalence of 26% in dogs with acute focal thoracolumbar myelopathy. This was significantly higher than previous retrospective estimates, likely because they focused specifically on dogs with a peracute onset of paralysis. They noted that the rate of onset was a key predictor. The faster the dog became paralyzed, the more likely they were to exhibit spinal shock. Importantly, they found that the presence of spinal shock was not associated with a worse long-term outcome, provided the patient still had deep pain perception. They urged veterinarians not to be deterred by depressed reflexes, as accurate localization can still be achieved by looking for other signs, such as a cutaneous truncee reflex cutoff or focal spinal pain. To help clinicians navigate these confusing cases, Rebecca McBride and her team developed a predictive model for spinal shock in dogs. They prospectively analyzed data from the International Canine Spinal Cord Injury Observational Registry and identified clinical variables that could distinguish between a true lower motor neuron lesion and spinal shock. Their final model included the weight of the dog, the duration of clinical signs, the severity of the injury, and the muscle tone of the pelvic limbs. Interestingly, they found that the odds of spinal shock actually decreased with increasing weight and increasing duration of signs, while paraplegic dogs were nearly 8 times more likely to have spinal shock than those that were merely paretic. This model allows for the calculation of probabilities. For example, a 5-kilogram dog with acute paraplegia of less than 12 hours duration has a 97% probability of having spinal shock rather than a lumbar lesion. This brings us to our primary deep dive into a recent review by Cohen Santafort and his international team of neurologists who explored spinal shock, the crossed Extensor reflex and the mass reflex in dogs and cats. This paper is a tour de force, summarizing literature and highlighting clinical observations that often fly in the face of traditional teaching. They emphasize that spinal shock is not always a symmetrical bilateral affair. They have documented cases of asymmetrical, lateralized, or even unilateral spinal shock, which can make a focal lesion appear even more confusing on a physical exam. One example they provided involved a 6-year-old crossbreed dog with acute non-ambulatory paraparesis who exhibited asymmetrical spinal shock on the left side only to be diagnosed with a left-sided thoracic ischemic myelopathy. Santafort and his team also tackled the crossed extensor reflex. Traditionally, we are taught that a crossed extensor reflex in a recumbent animal is a sign of a chronic upper motor neuron lesion, signifying that the spinal cord has had time to reorganize and become disinhibited. However, their collective observations have found this reflex in patients with peracute myelopathies, occurring within hours of the injury. In one instance, they recorded a crossed extensor reflex in a mixed breed cat just 24 hours after a traumatic vertebral fracture. They also described a Weimaraner with an acute cervical hydrated nucleus pulposus extrusion that showed crossed extensor reflexes in both the pelvic and thoracic limbs. These findings suggest that the reflex can emerge much faster than we once thought, possibly because some animals have pre-existing subclinical myelopathies or because certain polysynaptic pathways are less affected by initial spinal shock. Even more radical is their documentation of the crossed extensor reflex in patients with lesions that are actually within the lumbar intumescence. They describe a 13-year-old cat with lymphoma affecting the 6th lumbar segment down to the cauda equina that nonetheless exhibited a pelvic limb crossed extensor reflex. This challenges the traditional paradigm that the reflex is strictly associated with lesions cranial to the intumescence. They hypothesize that this could be due to maladaptive plasticity or the fact that even an incomplete lesion within the intumescence can leave enough local circuits intact to produce these hyperexcitable responses. The third phenomenon discussed by Santafort is the mass reflex, a constellation of involuntary autonomic and somatic motor responses occurring below a severe injury. This might include sustained contractions of the limbs, rhythmic tail wagging, and even reflex urination or defecation. While classically described as a chronic sign in humans, the authors have observed mass reflexes in the acute phase of spinal cord injury in dogs. One such case involved a dachshund with an acute intervertebral disc extrusion who, when his cutaneous Trunzi reflex was tested, responded with contralateral pelvic limb flexion and tail movement. Remarkably, they have even seen mass reflexes occurring concurrently with signs of spinal shock. A crossbreed dog with a lumbar intervertebral disc extrusion presented with flaccid tone and absent reflexes, the classic signs of spinal shock. Yet when its tail was stimulated, it exhibited rhythmic wagging and tonic flexion, a mass reflex response. This unusual clinical picture serves as a warning to clinicians. These phenomena should never be interpreted in isolation as indicators of chronicity or prognosis. As we move from diagnosis to treatment, the work of Deborah Gouveia and Angela Martins focuses on the importance of early intensive neurorehabilitation. They conducted a prospective study of 371 dogs with severe spinal cord injury, evaluating them with a new spinal shock scale. This scale, which ranges from 0 to 7, looks at muscle tone, spinal reflexes, and the cutaneous Trunzi reflex to quantify the severity of the shock. They found that dogs with higher scores on the spinal shock scale at admission had a longer time until recovery and a lower overall rate of ambulation. However, by implementing early intensive protocols, including land and underwater treadmill training combined with functional electrical stimulation, they were able to achieve ambulation in nearly 67% of dogs with spinal shock. For dogs with acute non-compressive nucleus pulposus extrusion, Gouveia and Martins found that while spinal shock was a negative factor for quick success, it did not prevent a positive outcome in the long run. Their intensive protocol resulted in 32% of dogs walking within 7 days and 90% walking within 30 days. Even among dogs that had lost deep pain perception, traditionally a very poor prognostic sign for this etiology, 75% eventually recovered, ambulation with the help of neurorehabilitation. They emphasize that the goal of this therapy is to stimulate the central pattern generators in the spinal cord, promoting the formation of new functional relays through repetitive movement and long-term potentiation. In the search for even more advanced therapies, Cameron Trueblood and Xiaoping Ho are investigating the potential of cell transplantation to address the most dangerous aspect of chronic spinal cord injury, autonomic dysreflexia. This life-threatening condition involves sudden bouts of extreme hypertension and bradycardia in response to stimuli like a full bladder. It is caused by the loss of supraspinal regulation and the maladaptive sprouting of primary afferents and interneurons. Trueblood and Ho have shown in rat models that transplanting embryonic presympathetic neurons from the brainstem into the injured spinal cord can reestablish neural regulation of blood pressure. These grafted cells project axons that reinnervate the sympathetic preganglionic neurons, reducing the occurrence and severity of dysreflexic episodes. This cutting-edge research offers hope for restoring not just movement, but the internal homeostatic balance that is so often shattered by spinal trauma. Finally, we must consider the eventual onset of spasticity, which was the focus of Kazuya Yokota's prospective cohort study. By evaluating 175 patients over 6 months, they found that the development of severe spasticity can be predicted as early as 2 weeks after the injury. Patients who showed an earlier onset of spasticity tended to have higher final scores on the modified Ashworth scale. Interestingly, they found that higher spasticity scores were associated with improved motor scores, suggesting that not all spasticity is problematic. In some cases, it may actually support motor function by providing a crude form of limb stability. This highlights the complex relationship between the injured cord and the recovery process. What appears to be a pathological reflex may sometimes be the nervous system's way of clawing back some semblance of function. The collective body of research we have discussed today reveals a medical landscape that is far more nuanced than our textbooks often suggest. Spinal shock is not just a clinical nuisance that masks a lesion. It is a profound physiological event involving motoneuron hyperpolarization and a flood of inhibitory neurotransmitters like glycine. The crossed extensor and mass reflexes are not just signs of chronicity. They are dynamic expressions of a disinhibited spinal cord that can emerge within hours of a catastrophe. And spasticity is not just a complication. It is a predictable part of the cord's attempt to reorganize. As clinicians, our task is to see past the flaccidity and the dead appearance of the limbs during those first critical hours. We must use models like the one developed by McBride to calculate probabilities and stay focused on accurate neurolocalization. We must use scales like the spinal shock scale to track progress and adjust our rehabilitation protocols. And most importantly, we must never give up on a patient simply because their reflexes are absent on day 1. The cord is a resilient, plastic, and highly complex structure, and even in the face of severe trauma, it is capable of remarkable adaptation. The scandal of spinal shock is that it forces us to doubt our eyes. It tells us the lesion is in the lower back when it is really in the chest. It tells us the patient is paralyzed forever when they might be walking in a month. By diving deep into the pathophysiology, from the glycine levels in the synapse to the axons sprouting in the indomescence, we gain the tools to fight back against that doubt. We can offer our clients more accurate prognosis, and we can offer our patients the intensive neurorehabilitation they need to reawaken their dormant neural circuits. Thank you for listening. The titles for the referenced papers are in the video description. From VetMed Digest, where we keep minds inspired, hearts light, and tails wagging,